Welcome to this video on the hormonal revolution in metabolic medicine, focusing on GLP-1 receptor agonists and the biological reframing of obesity. Please note, this content is for general awareness and is not a technical handout or a treatment guide. There is a paradigm shift occurring in how we view excess weight. Historically, it was seen as a character flaw requiring willpower. The modern GLP-1 view recognizes it as a chronic metabolic disease driven by biological pathways and hormones, requiring hormonal regulation as the standard treatment. The breakthrough originated from targeted interventions for type 2 diabetes. The discovery was that mimicking the natural GLP-1 intestinal hormone improved glucose control and promoted massive weight reduction. This led to new drug classes, including liraglutide, dulaglutide, semaglutide, and tirzepatide. GLP-1 works across multiple systems. It signals the brain to reduce hunger and increase fullness. It slows the stomach's emptying after meals. In the pancreas, it increases insulin release and reduces glucagon output, helping to manage blood sugar. GLP-1 has a dual-action satiety mechanism. Neurologically, it downregulates biological hunger signals, leading to reduced food preoccupation and smaller, satisfying portions. Physiologically, it slows stomach emptying, producing prolonged fullness and reduced post-meal hunger. GLP-1 provides dynamic blood sugar control by increasing insulin and reducing glucagon. Unlike older medications, GLP-1 mimetics generally carry a low risk of hypoglycemia when used alone, as they adjust dynamically to glucose levels. The efficacy of GLP-1s has improved significantly. Older drugs achieved 5 to 10% weight loss. Semaglutide reaches 10 to 15%, and tirzepatide achieves up to 20% plus body weight loss. These results are approaching the effectiveness of some bariatric surgeries. The systemic benefits of GLP-1s are broad. They offer cardiovascular protection by reducing heart attack and stroke risk. They improve fatty liver disease, lead to blood pressure improvements, and ensure better diabetes control through improved glucose and HbA1c levels. Patient qualification for GLP-1 therapy centers on two profiles. Patients with type 2 diabetes, especially where weight loss is desired, qualify. For obesity management, qualifications include a BMI of 30 or higher, or a BMI of 27 or higher with comorbidities like diabetes or hypertension. The tolerability timeline curve illustrates initial gastrointestinal symptoms, such as nausea, which peak during dose escalation. Most side effects become less severe over time as the body enters the adaptation zone and abdominal discomfort improves. GLP-1 therapy is not a magic bullet. Response varies based on genetics, underlying metabolic health, diet, and physical activity. The medication helps control hunger, but it does not eliminate the need for healthy eating, exercise, and adequate sleep. Obesity is a chronic disease requiring chronic management. If medication is stopped, a biological weight regain often occurs. Long-term treatment is physically necessary for many patients to maintain biological hormone regulation and the sustained weight loss. The new architecture of metabolic health is centered on GLP-1 biological regulation, providing systemic clinical benefits like reduced liver fat and improved labs. This regulation, combined with healthy habits, forms the foundation for long-term adherence and sustainable change. This content is supplementary information and is not intended for clinical guidance or patient management. It should be used with official course materials. While due diligence was exercised, content may become outdated quickly.